So Joanne is going to do my eulogy when the time comes, because she's already got it written out. Thank you so much for coming. I know some of you are coming for because you just love me. What can I say? So I just wanted to share with you just a little bit about my dissertation. Believe me, it was a journey. Dissertation is always a journey. And so going back to it, it seems less of a task than it really was at the time, because you forget some of the difficulties along the way. So it's kind of nice to look back at it and say, oh, cool, I really did that. My dissertation title was An Intervention to Test the Adolescent Maternal Confidence Learning Model. Now, I could have come up with something whimsical or cute, but I didn't have the brain power at that time to do that. So that's where it stayed, that point. As you know from what Joanne said, my background is maternal child nursing. And one of the things, the phenomena when you're looking at research and what topics to choose, you always go back to what is your passion. And my passion was women's health. And one of the things, the phenomena that I saw over and over again in women's health was we have a lot of adolescent moms in West Texas. And they have a lot of needs. And when we're getting them in and turning them around in 24 hours, sending them home with a baby, and they don't even know how to take care of themselves, that's a challenge. And so I knew right away that I had a perfect topic when I was looking at adolescent moms. One of the things we do know, and all of you that are mothers in here know, that motherhood can be one of the most rewarding times in your life. As an adult, it's challenging. But when you've not even accomplished your adolescent developmental stages, it just triples the challenges. How mothers adjust can be very influenced by the confidence they have in their role. And I know, I hear nurses, I hear other people talking that they're like, I was 35 when I had my first baby, but I was scared to death going home with this child. Imagine what a 13-year-old feels when they go home with a child. Maternal confidence has been identified in the literature as an essential variable in the adaptation to motherhood and the maternal role. So the purpose of my research was to test my Adolescent Maternal Confidence Learning Model with an educational intervention that I designed called Baby Basics 101. During that intervention, group classes were taught to prepare mothers, not only while they were raising their children, but also some of them before. So it was taught during the last trimester of pregnancy all the way up to the first year. So it had a fairly broad scope. The study was guided by 3 theories. Mercer's theory in 1985, and then it was revised again in 2004. That's maternal role attainment, or she renamed it Becoming a Mother theory. Einstein's 2007 3 stages of adolescent psychosocial development. One of the things that he proposes is that not all adolescents are the same. If you have a 13-year-old, far different animal than that 19-year-old as far as their ability and even their cognitive ability. Just think of your own children and how much care and how much you have to still follow them as a 13-year-old. Now, I know you're still doing it at 19 as well, but really by then they're starting to get it a little bit, much more than the 13-year-old. You hope so anyway. And the third theory was Bandura's social learning theory. So what this is the model of my Adolescent Maternal Confidence Learning Model. And the large piece that you see, the big circle, this is actually Mercer's model of becoming a mother. And that there are many different variables that impact your ability to become a mother successfully. The addition in this model that I added to it, I don't know if this thing is working. There it is. I looked at the stages of adolescence, Bandura's social learning theory, how we learn, and then actually developed the Baby Basics 101 program because of those theories, with the assumption that if these things are taught in caring for an infant, that maternal confidence would increase. When maternal confidence increases, then the attachment to the child would increase, and they would encompass the role of mother. And so that's really how I took the theory. The study was a quasi-experimental intervention, and I know for some of you that are not that familiar with quantitative design, this study, actually I had a group that I did an intervention, another group that was my control group. So it was two different groups, pre-test and post-test for both of them, for both groups, because I wanted to know if over a period of time, if time itself would increase confidence in my control group as opposed to my intervention group. The design was structured with one treatment and one control group. Now, my control group was alternative high schools offering classes to pregnant and parenting adolescents. And my intervention groups were teen parenting support groups. Just quickly on that, is one of the reasons I chose those is that those were places that adolescents were captured. If you think of the difficulties of doing research on adolescents, many of them don't drive. How do you get them there? You can't say, we're going to have a class, y'all come, because they can't all get there. So you have to have them where they're captured already, where you can actually keep them, well, not captured, captive, but you know what I mean. You know what I mean. There were 102 participants in my study. My control group had 56, intervention group had 46. The average age was 17 years with a range of 13 to 20. So that tells you just a little bit about what's going on in our community. Hispanic population, I had 74, which was 71.8%. African Americans, 11.7%. And they might have identified them as either mixed race or they might have been Asian, were 8.7%, and then 4.9% were Caucasian. When we look at adolescents, 64.1% had less than 12th grade education. Now, you would always figure, I mean, that's going to fall in that age range anyway. So more than half had less than 12th grade. 27.2% had 12th grade education, 1.9% had some technical school, and 3.9% had some college. So we are seeing that creep up just a little bit. When you look at stages of adolescence, the 13 to 15-year-olds, I had 14 in that group. Scary when you think about a 13-year-old parenting. Middle adolescents, 16 to 17-year-olds, 39.2%. Late adolescents, 18 to 20-year-olds, 47%. When you look at previous child care experience, that was important to me because I wanted to know how much they already knew. 74.7% stated they had some to a great deal of previous child care experience, whether it was with a sibling, a cousin, or another member of the family. 21.3% said they had little or no child care experience prior to becoming a parent. I used SPSS 19.0. I did univariate one-way ANOVA, an independent t-test, and some correlation. I had 6 hypotheses in this study. Hypothesis number 1 stated there will be significant differences in the maternal confidence of mothers in early, middle, or late adolescence, both pre-intervention and post-intervention. One of the things that just slayed me right from the beginning whenever I started running the data is there was no difference. Their maternal confidence had not increased. And I thought, there goes my whole study. They don't have any confidence, or no increase in confidence. But I found out that was probably one of the most interesting things that had happened. When I looked back and just looked at averages, like mean scores, my early, middle, and late, if you'll look at that, this is the pretest. You can see they all increased, although it wasn't statistically significant. There was an increase for all of them. when you looked at the average scores. My second hypothesis was that there would be a significant difference in maternal confidence of mothers who participate in Baby Basics 101, which was my intervention, versus mothers who did not participate, so my control group. I did independent samples t-test, and once again, there was no statistical significance between mothers who had the classes and mothers who didn't, and I was like, oh my word, what am I going to do? Believe me, I was freaking out. When you look at the two groups, the intervention group, which is the kind of golden color, and the control group, which is green, you see that although it was not statistically significant, which is a calculation you do using SPSS, it does show that it did increase over time, although it wasn't counted as significant. The third hypothesis, there will be significant differences in maternal attachment of mothers in early, middle, or late adolescence, both pre-intervention and post, because I'm also looking at, as they gain confidence, they attach to their babies, gaining the role of becoming a mother. So I'm looking at attachment also. Once again, there were no statistically significant differences between the intervention group and the control group. Okay, I'm crying by this point. When you look at your pre-test and post-test though, on the early and late adolescents, which are the gold and the kind of the brown color, you do see an increase in the averages of their scores. Middle adolescents, there weren't. But consider the age group, 16 to 17-year-olds. One of the things that was occurring, I believe, in this study is that when they came in, they believed that they were already very confident. You know your kids, they can do anything. You know, the world hasn't kicked them down enough yet for them to have any lack of confidence, but they truly believe they can do anything. So their initial scores were really high in attachment and in confidence. Attachment was interesting because it had not really been measured in adolescence. And so some of the questions on attachment were, when I look at my baby, I feel love. Okay, so if you're a 16-year-old girl and you're looking at your baby and you want to scream, are you going to tell me? Why? Probably because a fear of CPS, a fear of some type of retaliation. And so you have to put yourself in the shoes of an adolescent when you're answering those questions, because it had not been tested with that group. I started to feel better by that point. Hypothesis number 4, there will be significant difference in the maternal attachment of mothers who participate in Baby Basics versus mothers who do not. Once again, they already initially scored almost the top. They scored everything at the highest number in their pre-test. So their post-test doesn't have any room to go up because they already have scored it so high. Hypothesis number 5, there will be a positive correlation between maternal attachment and maternal confidence of adolescent mothers participating in Baby Basics 101. At post-test, there was a positive correlation found for the Baby Basics 101 group. Correlations between the change scores were compared and were weak, but they were significant for the group in Baby Basics. So hypothesis number 6, there will be a significant difference in the level of knowledge of mothers who participate in Baby Basics 101 versus mothers who do not participate. And this was my caveat. This was the piece that I was like, this has got to make a difference. And it did. It was significantly, it was statistically significant. And that's what you want to see whenever you're doing an intervention. So the Adolescent Maternal Confidence Learning Model, in order to test the model, there was a correlation of maternal attachment and maternal confidence of mothers participating in the intervention. Adolescent mothers participating in the classes had a significant difference in the level of Baby Basics knowledge when compared to the control group. So anytime you do a study, the put your life and your heart and your soul into it, and you come up with all this data, and then you have to look back and say, but what were some of the issues related to it? Because there's not any study that is perfect. They all have some things that you would change, because when you go into it, you're like, oh, I should have used this instrument to test attachment rather than this one. And so you start seeing things you would tweak. I used a convenient sample, and I didn't do a random sample because that's so difficult to obtain, especially in an adolescent population. And so my sample was convenient, which means that I found them. They didn't come find me. I did have a lot of similarities in my sample. Ethnicity, a majority of them were Hispanic. Education, a majority of them had less than 12th grade education. But when you're looking at their age, that's to be expected. And those things would also limit generalizing it to the rest of the population. I did have small effect size for maternal confidence and maternal attachment, and I think that those things could be tweaked in the future and future studies. I definitely probably would look at a different maternal attachment instrument, because that one, right off the bat, they scored almost the highest score in pretest. So it probably wasn't the best with an adolescent population. Groups for early, middle, and late stages of adolescence were uneven. It is very difficult to capture the youngest adolescents, because if you figure, youngest adolescents are from 11 to about 14. Those kids many times are not even in your high schools. Those are in your middle schools, and in some schools, some smaller communities, they may even still be in 6th grade, 5th or 6th grade, which is very frightening. So they're harder to capture. I also had use of self-reported data with regard to maternal confidence and maternal attachment. So they looked at the instruments, the tool, the questionnaires that I gave them, and they reported. And you don't know when you're handing them that if they're sitting there thinking, what does she really want me to say? What's she looking for? You would hope that they would look at it and just answer honestly. But many times, especially when you're dealing with adolescents, many times they'll try to give you what they think you want. The length of time between pre and post testing, it was over a 4 to 6 week period. And that was really because of the places I was going to. I had to do it within that period of time because school was getting out. By the time I got it approved, school was getting out. I needed to have it completed. So that, it probably could have been done. We might have seen some bigger things come out of it if I'd gone 6 months. But then recapturing them after they leave school for the summer and come back would be very difficult, that population. Baby Basics Knowledge Survey had moderate reliability, and there was a couple of questions probably need to be changed, and those could be changed in future studies. Some of the implications for nursing. Believe it or not, adolescent moms are eager to learn. I know we write them off and say, oh, they're just bad girls that just, they're going to figure it out themselves. They don't want me interfering or intervening in their life. These girls are desperate for information. I had 102 agree to participate in my study. 102 finished. Now, when you look at attrition in any study, when you look at adolescence alone, you usually will lose 50%. I kept 100% of the population in my study, which is amazing. That tells me that these girls are desperate to have someone intervene for them, someone to tell their story to, someone to give them some basic information. What do I do when my baby has a diaper rash? What do I do? How do I use a thermometer? How many nurses send people home from the emergency department and say, take your baby's temperature, and they don't even know how to do it? So those basic things that they need, those things that you would think that your mom taught you, but maybe their mom is only 22 or 23. It's a cycle with these girls. I do know that the Baby Basics 101 was designed at a very basic level for adolescent moms, and it was received well by these girls. Using the program or programs like this will help young mothers to increase their knowledge of infant care, leading to improved outcomes for mothers and their children. And that's what we want. We don't want children to stay in the system and to continue to repeat the cycle that their grandmother, their mother, and they've fallen into. That's really almost expected in their family. We want them to push themselves out. Future studies need to be conducted with more classes over a longer period of time, and that is something I'm looking at for future. Increase the number of early adolescents between 13 and 15 years old, and even earlier if I can capture them, because we have younger and younger girls having babies. Include the father of the baby and others who aid in the care of the infant. This was one of the most interesting things. I had dads of these babies come up to me and say, "Is there a class for us?" Who would have thought that? Well, I didn't design the study to include them, but I thought, oh my word, these dads are seeking information too. They want to do the right thing, and they want to know how to care for their children. And so it was very important. You've got to listen to them and hear what they're saying. It needs to be replicated to gain support of the conceptual framework and to increase the generalizability of the findings. I definitely would use a different measurement for maternal attachment, because that did not work well with the adolescent population. So in conclusion, becoming a mother is one of the most important social roles in an individual life. A mother's confidence in her ability to care for her infant is necessary for healthy transition to motherhood and a positive mother-infant relationship. When nurses, who were well respected by these girls, they seek us for information. When nurses are willing to address their problems and their issues and their questions in a developmentally appropriate manner, don't go in and talk doctorese. Don't use big words, and you may have to get on their level for them to understand. Ask them, do you know how to use a thermometer? You want me to show you? Don't roll your eyes at them and go, really? So it's really important that as nurses that we developmentally appropriate information to increase their knowledge and to provide care for their infants, improving outcomes for mothers and infants. Those are my references.
Dr. Thomas will invite you to stand where you are. You're welcome to come up front if that's, do you think people can hear you better?
Yeah, I think I will.
Okay, that'd be great. Thank you.
Congratulations. This is a wonderful piece of work. A wonderful piece of work. And I don't know whether I need a microphone. I can talk very loud.
I'll stand by you.
Okay. But I just want, it's a wonderful opportunity for me to always be with certainly a group of nurse scholars, and you all are nurse scholars, but to be in the presence of someone who has done original maternal, infant, or maternal child health research. It's very exciting, and I want to thank you so much for doing this great work. And our paths have crossed several times. I have had students from Texas Tech on the OB units, and that they have had the benefit of your wisdom and your patience with them when they were doing different rotation groups. But one of the things, I don't know whether Dr. Long even knew this, but I did perinatal case management, and the type of students, the young girls you were talking about, those were my folks in rural Georgia for 5 counties. And one time people would say, why are you, this must be so discouraging to work with these young girls. But it was truly the most uplifting, and it changed my understanding of nursing. I tell people that's when I became a nurse, because I learned so much from these very brave, energetic, often crazy and edgy young patients, but they helped me understand the complexities that I didn't really understand when I was in the intensive high-risk labor and delivery units that I had worked at most of my life. So the value of, I just want you to know, the value of your work is truly, it's truly very exciting, because I know what it's like to be in the trenches and to realize that the most important thing is you need to find a way to help this young woman who's in a very a crucial stage in her life, for her to have victory, for her to feel like, despite what this is, something awesome can come from this. And the study is really exciting. So, well, thank you very much. And I, you know, as a good student, because I've been a student a lot of my life, I took a lot of notes. And I took shaky notes because I had too much Diet Coke before it came. But one thing I want everybody to realize, that stepping out to do original research is really scary, because you think you know what you want to study, but you are going into virgin territory. You've never been there. I mean, you really don't know what it's going to be like. I didn't do a study that was quasi-experimental. I did a qualitative study. So that's why this is such a beautiful study for me to hear, because so many things that you brought out. And I just want to share a couple things. You know that beautiful model she had up? That takes a lot of thinking, a lot of painful thinking to get to that point. And that's the creative piece of being a nurse scholar, being a clinical scholar, is that you say, okay, based on what all these wonderful people have done before, how can I bring this together? The model's beautiful. Thank you. And I don't know whether you realize it, but it's pretty exciting work to see somebody work through the challenges of other people's theories and say, how can we bring this together and make it something that's valuable for labor and delivery nurses, for folks out in the community, people like me who've done perinatal case management. It's an exciting, groundbreaking. So thank you very much. All right, so like I tell you, I did write a lot of very quick notes, but I wanted to share with you a couple things. You know, many of you, when you listen to a research piece of work and somebody says, okay, this is my hypothesis, and I thought that this was going to happen, and then I didn't see a statistical difference. And then another hypothesis and another hypothesis. Oftentimes, you don't hear that kind of thing being printed, right? You see a lot of great studies about stuff that was really, oh, this is exactly what we thought we would see. It's when scholars share with you, this is what I thought, this is what I did, and it didn't work out exactly what I thought, but those hypotheses that don't always come cleanly in the direction we want them to come, that's where we learn so much. And so for a scholar like Dr. Harrison to share that with you, that's exciting. And you need to, put that in the back of your mind. Science is messy, but it's exciting. And when it doesn't always work out great, that's when we learn so much more. So I wanted to make sure that you heard that. That is never a bad thing. When you hear a researcher say, okay, I thought this and this happened, which I was frustrated or scared or angry or, oh my gosh, I invested all this time in it. Those are the times when you really get groundbreaking understandings that you didn't think you'd get. So thank you for sharing that with us.
Thank you.
Because that's hard. It really is hard. Another thing that I thought was so exciting is that you were bringing forth, you had these beautiful hypotheses, and you were looking at the need for these young new moms to gain a certain confidence, to reach that point that they could tackle this really tough thing that life had given them. And as much as we love the idea that they would become very confident, sometimes it's very valuable to look at things from a different perspective. For example, when you're a student and you don't do that great on a test, what do you know? You know you need to work at something. You know you need to learn. You need to ask people for help. You need to get a tutor. You need to go back and talk to the instructor, find out where you went wrong. Sometimes I think that when we don't realize that people, when they are at a lesser point of confidence, that may be when they're the most teachable, the most receptive. And certainly in population health work, I've often seen that it's when they realize, I don't know a lot. That can be the opportunity when you can say, let's work as a team. How can we get you to that point? So that's another great thing I like about this study, because that could be a whole different area that you could go. And I'd be excited to see how that might turn out. But I know, for example, with a lot of my new moms that I worked in rural Georgia, they would start out, oftentimes, this is a terrible phrase, we used to call them train wrecks, Life was awful, their house was chaotic, they didn't go to their appointments, they didn't know what medicines they were supposed to take, they didn't know when the baby should come to the appointment. But it's often in those points of chaos that there's these great opportunities, that you can help them to have little points of victory. And that's what a lot of really great public health or maternal infant interventions are all about. Helping people get to that little point of victory and building on it and building on it. So there are so many wonderful takeaway points in Dr. Harrison's presentation. I just want you to realize, you may not realize it because it's the end of a long day, but this is pretty exciting stuff. And I want you to get really pumped up, because there's a lot of things here that were presented that can build so much new knowledge and inform how we tackle working with these new moms. Another thing that I wanted to share with you is that she said someone to tell their story to. I'm a qualitative researcher, and I'm all about hearing people's stories. But often one of the most important interventions is for somebody to be invested in that person, to listen intently. We know that. Nurses' use of self. We know that. But sometimes we think that it has to be an elaborate intervention, when oftentimes it can be that simple intervention that's spending time. So Dr. Harrison might even say, maybe I'll not so much be concerned about the content, but the nature of the interaction of the person who teaches the course with the students. And there's so many things, there's so many ways you can go in this direction. So you should expect to see some great stuff. And a couple of things I wanted to say, that anytime you do studies like this, it's very, very challenging. She listed the limitations. You should always expect to see a good researcher tell you, these were my limitations, this is what I know were problems. And sometimes you couldn't fix them. Sometimes you absolutely can't because you don't have enough time or enough money. Or you can't, there's another way around it. It's challenging to work with any time you have young people, because those are minors. So Dr. Harrison really tackled a big problem, and I think she did it with elegance and grace. And I want you to know I'm very excited, and thank you for letting me be here to hear it.
Thank you.
It's a pleasure. Thank you very much. Thank you.
Dr. Thomas, we really appreciate that encouragement and also the dialogue and scholarship. That's a good bit of what we're trying to do here, is just create a forum for alumni, students, friends, colleagues to talk about how can we improve care. So there's so many. Do we have questions of Dr. Harrison?
Yes, ma'am.
I have actually a couple of questions. How did you decide what content to include in your Baby Basics 101? And do you see it being used in hospital settings maybe as well as in the community?
I really think that it's best in a community type setting because of the time involved in teaching. But the way I got there, to answer your first question, was honestly I just hit the literature. What was out there? What were adolescent moms, because a lot of research has been done. What are they saying they need? What do they wish they had? Because those qualitative studies had been done on, the moms and their experience of having a baby. And so I really looked at the literature and determined the items that they needed, and much of it was very basic. Now, a lot of what they said was also care for themselves, but I had to limit my study to be able to have something I could handle. And so I looked at how do we address the infant issues. And so there's many other ways you could take it. The Baby Basics 101 is about a 50-page, just page by page, how do you do it, from sectioning, what do you do if your baby has a cold, when do you seek emergency medical care, what skin rashes should you be concerned about, what vaccinations should your baby have, and when should they have them, and should they have them, and opening those dialogues. So really I looked at the literature, and that's how I developed the program itself. There are some things out there, some programs, but I really wanted to do something that really fit for my study and what I was looking at. Yes, ma'am.
What size were your groups, and how often did you meet with them?
I met with them once a week, and it depended on which location I was at, but for the most part I had about 10 to 15. And really you cannot help but develop relationships. Okay, I can't help but develop relationships with people that you're interacting with. And so I knew their kids' names by the end of it. By the end of 4 to 6 weeks, I knew what was going on with them. So, but I had to meet at each location several times a week to be able to get them, because there might be a time that a mom was out sick with a baby or something, and so I'd catch her the next time.
Do you think it made a difference in the study at what stage the mom was in, as far as their pregnancy, or how was it?
That really didn't come out as being a significant issue. At any point, whether they were in their last trimester of pregnancy or their child was a year, they all had the same learning needs, and they all wanted to know. So I didn't see that the ones that had not delivered their babies had a greater need than the ones that had babies. They all had, it was pretty even.
I know you did this for your research, but is this an ongoing thing you're going to keep doing?
Yes, as soon as I have some time. I do intend for it to be ongoing, and I'm working on an article right now to try to get published with my dissertation, and then as to pieces, I would look at pieces of it. I would love to develop the tool, Baby Basics 101, as to be something that people could take and they could teach, adolescents. I would love to further develop it, and it has some rough edges and needs to be developed. But that's one piece of it I would love to take and develop. Camille?
Do you see the school nurses being able to implement that program?
Yes. Very, very basic and very, in fact, when I was the control group that didn't have the intervention, the agreement with the school system was that at the end I would come back in and teach the classes. They didn't want to allow me to come in if I was just going to come collect data and walk away. So at the end I came in and I taught the classes to them, and was just received really good response from them. Hey, Amanda.
Did you have the situation come up where it was any of their second baby? Did you exclude people that
I didn't exclude people that it was their second baby, and I did have a 15-year-old that it was her second. But the knowledge deficit was still there. Yeah. Neil.
Well, as a parent who used to have children in school, I know that whenever they were going to take some particular classes, they had to get parental permission. And I know your study was 102, I believe, that you had in your study group. Did you? How many did you have that were resistant to that? That kind of like, no, we don't want our child going through.
You know, honestly, I had great reception from. One of the things that happens, because a majority of them were under 18, and even though if they go in as a 13-year-old, have a baby in the hospital, they sign all their consents, but as soon as they've delivered their baby, if they need an appendectomy, their mom has to sign for them because they're not considered emancipated minors. And so I had to get consent from the parents or guardians and an assent, which was a form that they signed that they agreed to participate, from the individuals themselves. And it was a huge challenge because I was double consenting everyone that came in. But I didn't have any parents say, I don't know. I did have one girl that she was very hesitant, and she came to me and she said, okay, now tell me about these classes. What are you going to be telling me in those classes? And so I did a little overview, gave her the same thing I gave everyone else, and she said, okay, I'll come try them. And she was there every time. It was not anything invasive for them.
How many classes did you conduct in the third trimester and the first trimester? Or is it throughout the pregnancy?
It was, no, if they were in their last trimester of pregnancy, they were eligible to come in, do the classes, all the way up to the first year. So if a girl had a baby that was 9 months old, she could come into the study. If someone was in their last trimester of pregnancy, they could come into the study. And so I didn't take any before the third trimester. It was just at the end.
Okay. Do you think early in the pregnancy would help them, these classes?
Early in the pregnancy, many of them are getting prenatal care. And it just comes down to capturing them where you find them. Many adolescents don't even determine they are pregnant until the second trimester. So, they're not, that aware, and many times, their own hormones and their own body is not functioning regularly for them to even know if they were pregnant. So, yes, ma'am.
Did you have an alternative for the fathers who wanted to be involved?
I did tell them that they could stay. They couldn't do any of the instruments. They couldn't fill out any of the forms, but I did tell them they could stay, and did have a couple of the dads stay. But one of the things that they would come in the hallway afterwards and say, hey, are you going to do something for dads? So it was very interesting. I mean, these kids look like gangbangers. I mean, you really wouldn't have thought that they would be that interested, but they were very interested. I was very touched by it.
Was this a class where the babies were present as well? If they actually
sometimes they were. I do have a model baby, a dummy that's a medical model that I did some demonstration with, and I never used a real infant for demonstration. But I showed like choking, things like that. I would use the baby for. I wouldn't choke anyone, but demonstrate. You know what I mean?
So do you get to do the comparison about the global health studies in the adolescent learning from other parts of the world, or is it just in the United States, your dissertation?
Are you saying what?
Your studies, what you're doing now, what you did, have you compared it to the global?
Well, I'll tell you that I did an extensive literature review, and I did not have any type of boundaries on it, and it was worldwide. What I was looking at, what moms are wanting, it's not any different what moms need here for parenting and moms in Kenya. It's the same thing. I mean, it's just we all have the same needs, and I didn't find anything different there. It's really universal. It could be used anywhere. Any other questions? Yes, sir.
I know your study was mainly concentrated on adolescent teenage mothers. But do you think this information, the Baby Basics 101, would be something that could be implemented for adults as well?
Absolutely. In fact, I had adults come to me and say, why don't they do something like this for adults? You know, I need this information. Nurses that were having babies were like, this is information I need. And so, yeah, one of the things we do is we do a pretty good job. You know, all of the data has come out on prenatal care, how important it is, and we do a pretty good job. Did you know that about 83% of pregnant women in the United States receive some form of prenatal care? Now, it may be only a couple of visits, but they receive some, which was actually way higher than what we really expected. But we do a good job front-loading them and giving them, this is what's going to happen when you're delivering your baby. You're going to have pain. You might need an epidural. These are some things. But we're sending them home with very little information other than the pamphlets that are flying around in the parking lot, because they're trying to get a baby in the car, in that car seat, and all the pamphlets that you just gave them flew out. It's a very poor way to teach. Okay, thank you for coming. Appreciate you.